So today's presentation is going to look at mucociliary clearance and the mechanisms for it, because it's really important that we understand that so that we can apply this to our peripheral airway clearance techniques and understand how they work, which will then help us to choose what technique we should be using with what patient, which I think is the million-dollar question. Now, there are plenty of diagnoses that benefit from respiratory physiotherapy, and they're not all listed here, but this is just to show that we deal with an awful lot of patients and we can help them in multiple ways. Physiotherapists treat people holistically, and so respiratory physiotherapy after optimal medical management doesn't necessarily just focus on airway clearance techniques, but obviously we are involved in optimizing lung function, ensuring that there is adequate or improved thoracic range of motion. And I think increasingly important is to recognise the issue within respiratory physiotherapy for patients with regards to continence problems. But today we're going to be talking about airway clearance techniques. Now, this is the natural way that secretions move, and that's via the mucociliary escalator, shown in this video of the cilia beating here. The normal ciliary beat frequency is around 10 to 15 Hertz, and the mucociliary escalator will naturally clear around 20 to 30 mils of secretions per day. But this, of course, is dependent on viscosity, the depth of the liquid layer, elasticity, airflow equilibrium, and the position of the airway and whether gravity is involved. And not just that, here you can see that where I'm highlighting on the bottom left, this cilia is beating impairedly. It's not beating the same as in the video above. And this is just someone without any issues with the mucociliary escalator when they have a common cold. So things can tip us over. But secretion movement is not just dependent on the mucociliary escalator. Breathing plays a part too. And this cartoon shows us that when we breathe in, here on inspiration, that the flexible airways expand. And on exhalation, when we breathe out, they contract. And what that does is it creates within the narrowing of the flexible airways, an increase in velocity and shearing forces, which provide an increased expiratory airflow bias, and that moves secretions towards the mouth. Now, this is a beautiful review, and the cartoon shows over the decades, so the 50s, 70s, 80s and 90s, the changing ideas and evidence that has occurred when regards to aiding the mucociliary escalator and enhancing secretion. So we have in the light bulb ideas, and that was around gravity, ciliary movement, and then we have bench studies providing further evidence and animal models. And I'm going to cover some of these concepts in today's presentation, and understanding these concepts will help us comprehend the mechanism that is involved within the airway clearance technique that I'm going to be talking about. So obviously secretions are moving naturally with breathing and the mucociliary escalator, but as physiotherapists, we want to enhance that secretion movement. And this slide shows two geographical traces. The first one on the left here shows the inspiratory flow and time above the dotted line, and the expiratory flow and time below the dotted line. And you can see that the proportion B, the expiratory flow, is less than the inspiratory flow. Whereas this graphical analysis shows the inspiratory flow, again, above the line, an increased time, and then below the line, the expiratory flow, which is greater, and a shorter time. And conversely, we can see that the expiratory flow is greater than the inspiratory flow. And what this means clinically is that the left-hand pattern will favour secretion embedment. It will push secretions down further into the lungs, whereas this one will favour secretion movement towards the mouth. and enhance secretion clearance. And this is demonstrated by where they put in their bench model the sputum here. They've provided a model that favours secretion clearance, and you can see that the secretions are moving towards the model as shown here. So what we've done is we have enhanced our airway clearance by generating a higher expiratory airflow bias than our inspiratory airflow bias, and we want that to be greater than 1.1, or our expiratory minus our inspiratory difference to be greater than 17 litres per minute or greater than 33 litres per minute, depending on which literature you read. But it means that we need higher flows. In addition to creating an expiratory airflow bias, we know that in the diseased lung and older lungs that there are collateral ventilation, the channels of collateral ventilation. And we can utilise those in order to help mobilise secretions. During quiet breathing, these channels are closed. The small tidal volumes are not great enough to overcome the resistance within them. However, by taking a deep breath in and increasing our lung volumes, we're able to overcome the resistance within the collateral channels of ventilation and go from a non-obstructed segment to an obstructive segment and get behind the secretions and help to move them up towards the central airways. So to put it in a bit of a simplified format, the physiological mechanisms for airway clearance in this are increasing the expiratory flow, oscillations within the airway, and increasing our lung volumes. Now, whilst we can enhance secretion movement, it's still important to bear in mind that cough is the primary mechanism of mucociliary clearance. And it's also important to note that a voluntary cough will be less effective, and we often ask our patients to take a voluntary cough. We don't wait for a reflexive cough, and a reflexive cough is always more effective as it will generate the airflow dynamics and changes and a further increase in the airflow velocity. However, it's not just as simple as that. There are other mechanisms which can be looked at in this great review by Hill et al. Describing cough in further detail, which I don't have time to go into and is not the purpose of today's presentation. Let's have a little look at what happens in disease. We know that disease can affect the lung, airway, mucus and secretions, and that happens to cause an increase in the viscosity of the sputum. It can impair the clearance via the mucociliary escalator, and we can also have an impaired cough reflex, and this leads to airway inflammation, infection from opportunist pathogens, an increase in airway obstruction and parenchymal damage and remodelling. And so if we're going to put this pretty much into a very high overview, so not going into detail, if we look at our patients with chronic obstructive pulmonary disease, they will have persistent airflow obstruction. Our cystic fibrosis patients, we have mucus hyperconcentration. We've got motor impairment of the ciliary function in primary ciliary dyskinesia. In bronchiectasis, we've got muco-oppressive and the neuromuscular disorders which cause an impairment in cough. And depending on the severity of the disease, you can see that you get changes in colour in the mucus. And obviously, I certainly wouldn't want this as a colour chart for my walls at the bottom. The lighter, the better. Now, when a patient comes to you, we are continually assessing our patients for where the secretions are. And we are making choices about what we want to do and what we want to target. And Louise Lanfors beautifully explained the process in which we can mobilise secretions up towards the central airways. So first of all, we want to get air behind the mucus to open up the airways. We then want to loosen and unstick the secretions from the smaller airways and mobilise through to the larger airways. And then finally, when they're in the central airways, there will be the ability to either have a reflexive or a voluntary cough to clear them. We defined the first 3 stages as peripheral airway clearance techniques or secretion mobilising, and the last, the cough, as a proximal airway clearance technique. So putting it into context with regards to the disease lung and the effects that we have, that disease has on it, the aims of the peripheral airway clearance techniques are to clear the secretions from the peripheral airways, to improve the mucociliary clearance, to decrease the mucus plugging, which by in turn getting rid of the mucus plugging and the secretions will help to decrease that local inflammatory response from the bacteria sitting there. So I highlighted respiratory physiotherapy has many components, but we're going to be concentrating on, for the rest of today's presentation, the peripheral airway clearance techniques with regards to 5 principles or 5 types: the flow acceleration, handheld positive expiratory pressure devices, breathing exercises, conventional treatment, and oscillatory generating devices which need an electrical power source. And I will be describing each of them to you now. Prior to doing that, though, I just put this slide in to be mindful that there are medications that are taken before and after airway clearance techniques, and we want to ensure that they're in the right order so that we can clear secretions effectively. There is no point in trying to clear mucus in an obstructed lung that's got huge amounts of bronchoconstriction because the patient has forgotten, for example, to take their bronchodilators. Likewise, if their secretions are thick and sticky and we're using mucolytics, we need to use those potentially before the airway clearance techniques, potentially with or without bronchodilators, or bronchodilators afterwards, depending on what fits with the patient. And then after our airway clearance techniques, once we've removed the secretions, we want to look at, if the patient is on inhaled steroids, them taking then to get better deposition along with inhaled antibiotics. So be mindful that you're making sure that your patients are taking their medication in the right order, and you'd be surprised at how many do it in the wrong order. So, as I said, what are these techniques? When it comes down to conventional treatments, we have postural drainage, and there's an example shown here. This utilises either positioning to drain certain parts of the lungs with or without gravity, depending on the position. And this will move secretions from the peripheral airways into the central airways. In addition, these are often used with manual techniques such as clapping, shaking, and vibrations. Vibrations will increase expiratory volumes. Chest clapping and vibrations increase oscillation and expiratory airflow. And chest clapping and vibrations may stimulate ciliary beat frequency and or change sputum viscosity. Chest clapping should occur with the patient taking deep breaths in order to prevent desaturation. Or if the patient is unable to take deep breaths, it should be for no longer than 30 seconds, again, in order to prevent desaturation. Shaking and vibrations should be performed when the patient is exhaling after a deep inspiration where possible. Again, in order to get the most optimal effects of oscillations within the airways. Let's take a moment to look at breathing exercises. Coming from the Brompton Hospital, where I was privileged to work with Jennifer Pryor, the active cycle of breathing techniques was my bread and butter. This technique consists of here, this is a diagrammatic example of it. We have breathing control, which is relaxed breathing. Initially, it was almost spoken about as diaphragmatic, but that can be very difficult for patients. So it's normal tidal volumes with a relaxed upper airway without them using their accessory muscles, followed by a period of thoracic expansion exercises, and that was usually 3 or 5. This consists of a deep breath in, where possible, trying to utilise a hold in order to allow airway equilibrium, followed by a period of breathing control, which would enable the patient to rest and prevent them fatiguing. The final component, although this can cycle for as long as is needed in order to mobilise the secretions, was the forced expiration technique. And this is a mid to low lung volume breathed out through an open glottis with a squeeze. And this technique produces dynamic compression and collapse of the airways downstream of the equal pressure point, creating a pinch point. And this increases the turbulent flow and utilises collateral channels of ventilation in order to mobilise secretions towards the mouth. This technique can also be adapted for patients who have ventilatory failure by providing ventilatory support, and I will talk about that in the next slide. But before moving on to that, another widely popular technique is autogenic drainage. This involves breathing at different lung volumes. The first phase, breathing at a low lung volume, so taking your patient right the way down, unsticking the secretions, and you listen and the patient tunes themselves in to feeling when they start to move. Once they start to move, you come up to a mid-lung volume, and again, carry on breathing at that level until the secretions are moving, and then come up to a high lung volume, which involves the secretions being evacuated. And what autogenic drainage does is it aims to achieve a high expiratory flow by narrowing the airway through the open glottis with a forced expiration, and slow inspirations with inspiratory holds. So all the time moving the secretions up. I also want to highlight, because not everyone listening to this webinar will be from the UK, that there are other techniques that are more popular. For example, in Italy with Eltgol, which is a slow expiration through an open glottis in a lateral position and is demonstrated here, clearing the secretions not only from utilising the breathing part of it, but also the positioning. And EDIC, which is a controlled inspiratory flow exercises, and also pictured here. Now, in patients who have ventilatory failure or fatigue easy, it is not always possible to do breathing exercises with those patients. And so these exercises can be modified, certain ones, to incorporate ventilatory support. And for the older physiotherapists in the audience, we will remember the Bird Mark 7 intermittent positive pressure device, which was our bread and butter and rolled out on surgical wards and medical wards for those patients who were fatiguing. For those of you less familiar with the technique, it's the maintenance of positive airways pressure throughout the inspiration, with the airway pressure returning to atmospheric pressure during expiration. And the device is triggered, so the patient must be spontaneously breathing. So if we think about the self-ventilating patient, here is their volumes here. And what intermittent positive pressure breathing is aiming to do is to produce this change in the tidal volume. And we're looking for at least an increase of 25%. And this is done by you setting the flow to give a slow, deep inspiration with a maximum pressure cutoff, allowing the patient to have a deeper breath in. You can also provide deep breaths in quite simply with a non-invasive ventilator by increasing the pressure or volume. So you're not just limited to providing pressure support with an IPPB device if you don't have one. Utilising IPPB and NIV will augment greater tidal volumes. It will also, with the inspiratory hold, help recruit collapsed alveoli. It will improve ventilation if set at a high enough pressure and arterial blood gases, which in turn decreases the work of breathing and rests the respiratory muscles, allowing you to utilise the expiratory airflow that you've gained by increasing the inspiratory volume and mobilising secretions, and with the holds and deeper breaths, utilising the channels of collateral ventilation, allowing secretions to be mobilised towards the mouth. The patients with less ventilatory compromise and that don't fatigue, we have handheld positive expiratory pressure devices, and this with breathing exercises tends to be first line prescribed treatments for individuals who have mucus production. So with these devices, they can be delivered via a mask or a mouthpiece. Typically, the individual takes a deep breath in and breathes out against the resistance, and the resistance is determined by a manometer, and it will be tuned to what pressures you want to be delivered to the patient, and that will depend on their condition and their lung disease. The smaller the hole, the higher the pressure that will be delivered to the patient. The patient typically takes 5 to 10 breaths and then may rest. If they feel that secretions are present, they can perform the forced expiration technique through the device or independently. This is repeated until the secretions are cleared, so treatment can take on average between 10 to 30 minutes, depending on the amount of secretions present. PEP devices can also be particularly useful in those individuals that have malasic problems, as it will splint open the airway and help prevent the collapse. Breathing against positive expiratory pressures quite simply prevents airway collapse. It will utilise the channels of collateral ventilation, and it can help because it's keeping everything open in decreasing hyperinflation. We also have handheld oscillatory PEP devices. These devices will give you the benefits of positive expiratory pressure, but the addition of adding in vibrations. Some of the devices you'll have to tune to the patient, and we've got examples in the middle. There are also devices, for example, the Aerobica, which will allow attachment of a nebulisation device, which can be useful if patients are needing nebulisation prior or during treatment. Again, some devices you may need to fine tune to the patient, and you will have to teach the patient how to use them. You can't simply buy them off the supermarket shelf and expect the patient to get the best result from them. Typically, again, you'll take 5 to 10 breaths with rests, and this will continue until the secretions are cleared. Some devices can only be performed really in a sitting position, whilst others can be combined, like PEP, and other techniques in positions of postural drainage targeting the lungs. So as I said, these devices have the benefit of maintaining the airway open through the positive expiratory pressure, but the addition of the oscillations can help to thin and loosen the mucus whilst the airways are held open. It should be noted that these devices have different vibration profiles, and this is shown on the far right hand portion of the slide. Here you can see some will produce more vibrations on top of the spontaneous breathing than others. And it's important that we don't necessarily take the results from one study and apply it to all positive expiratory pressure devices, because they may have different effects to the patient, and one may be superior than the other, although this has not been quantified in research. Let's move on to devices now that need an electrical supply or an air supply in order to provide the oscillatory therapy. So this is some examples of devices that are out there, and they provide oscillations that are either within the airway, because it's been delivered, the oscillations via the mouth and the upper airway, or that there is a device that fits around the chest providing external vibrations. When we think of the physiological effects of these oscillatory devices, some will aim to prevent airway collapse. They will increase our expiratory flow bias and thereby enhance airway clearance. We have, again, the same as the oscillatory PEP devices, that the vibrations could loosen secretions. And again, for both, there is unsupported speculation that the ciliary beat frequency may be enhanced with these devices, or that they could indeed provide a phenomenon like mini coughs, so open and closure, dynamic closure of the airway, which will help to move the secretions up. So if we look at the devices that are applied to the chest wall, we've got high frequency chest wall compression and high frequency chest wall oscillation. These devices, again, have to be tuned to the patient via working out which frequency is going to optimally move secretions for them. And usually that's something between 10 and 15 hertz. Although there are devices and programs preset within the devices that have been used clinically in certain groups of patients in order to mobilize secretions, and that's one way that you can use them. Again, typically treatments might take up to 30 minutes. You may have 5-minute periods and then take the patient off, encourage them to huff or cough, or provide in patients with neuromuscular disorders a cough augmentation technique. So if we look at high frequency chest wall compression, which is technically the correct term for the vest device, smart vest and others, what this does is it provides a wrap device that fits around the thorax that inflates, and that can take people into their closing volumes and may be a problem, or it may not. There is then a flow interruption by the device that's fitting around the thorax that causes the vibrations internally that mobilize the secretions up. And then we've got high frequency chest wall oscillation, which rather than a wrap involves a cuirass that fits around the chest wall. This then sucks out with continuous negative pressure and will provide positive expiratory pressure within the lungs because it's sucked out. And that gives us the PEEP effect. There are then oscillations that are on top, which is a flow interruption that causes it within the chest. And these can also be stronger, mimicking a cough, should that be required for individuals. We then have the devices that are involved via the upper airway. So in this situation, the devices are provided via a mask or a mouthpiece. The first one we have is a metaneb, and this is a system that combines continuous high frequency oscillation with continuous expiratory pressure to keep the airways open. Both of the devices that provide this high frequency will have the ability to add nebulization, because the high airflows can make the patients feel that the technique is very, very dry. When it comes down to the metaneb, it has 2 frequencies, 230 beats per minute and 170 beats per minute. And you can set the pressure to be either the continuous expiratory pressure to be low, medium or high. Its limitation is that this one requires a hospital oxygen source in order to run. You have the percussion air devices, which usually run off a compressor type system and don't always require a oxygen source, and in the majority of cases don't. This is a pneumatic device that delivers very small tidal volumes to the lungs, and it's via a phasotron effect, which you can see here. It has an open system, and it can provide a frequency of 600 to 60 cycles per minute at a varying pressure. And if we just, I don't know whether my video, it stopped playing because I'm talking so much. So this is what you're expecting that the air gets behind, but this is showing secretions that have been placed at the lung level and the vibrations moving them towards the mouth, and that's effectively how it's supposed to work. When it comes down to settings for IPV, typical IPV devices like the percussion air, we need to think about what we set. We set the percussions or the frequency the inspiratory to expiratory ratio, and the pressure that's to be delivered. And this, even though it's in French, has some beautiful diagrams and is pretty understandable even to me, whose French is rubbish, but it shows the inspiratory and the expiratory component of the breath with the vibrations on the top. And you can see that during the expiratory component that there is a positive expiratory effect, keeping the airways open if the frequency is high enough. If the frequency isn't high enough, you don't get that effect. The oscillations will, if the pressure is high enough, will open up the airways. They will also provide a PEP effect and hopefully mobilise the secretions up. And the final setting is the IE ratio. This can be set to provide ventilatory support as shown here and can actually ventilate a patient whilst they're on it. So, as I've said, the more the frequency, the greater the PEP effect. You can manipulate the IE ratio so to provide ventilatory support, and you want to set the pressure to be high enough that you can feel the vibrations on the chest wall, within the chest wall, when you compress the chest in order to know that it's mobilizing secretions from the peripheral airways. And this is a technique that can also be combined with other techniques, for example, chest wall strapping, and I'll talk about that. The final device, or the newer kid on the block with regards to external vibrations, is PhysioAssist or Simiox. What this does is it provides intrabronchial oscillations during the expiratory phase. So the patient will breathe in and out of the mouthpiece. They breathe in without any resistance or anything happening. And as they breathe out, they push this button, and the short timed repeated negative pressure between 6 or 12 hertz is delivered. And that, as you can see in the video, gets behind the secretions and mobilizes them up. And it may have an effect on modifying mucus viscosity and elasticity. Studies have shown that this may be a technique that is beneficial for patients with cystic fibrosis, and that's where the research has been started. And it may have, although we don't know because the formal studies haven't occurred to that, in other suppurative lung diseases. The final group of techniques to discuss are flow acceleration techniques. Chest wall strapping is one of these, and as I've said, it can be combined with other techniques like IPV or breathing exercises. It was first documented in the 1960s as an experimental procedure that induced breathing at low lung volumes. And what this does is it provides a maximum expiratory flow that is increased in normals, and that's what's been shown to happen. But you also see increases in lung recoil and reductions in pulmonary compliance. The increase in the lung recoil with the chest wall strapping might explain the observed increase in the maximal expiratory flows. And remember, expiratory flows are what moves secretions. Chest wall strapping has also shown to decrease closing volumes, and it's suggested that the increase in elastic recoil leads to dilatation of the smaller airways, and that's seen here in this. So this is a control, and this is a CT scan that's been regenerated of an individual that has been strapped, and you can see that the lung generations is far greater. And the volume that is seen of these units in a normal subject that is strapped is greater than a control normal that's not. And that is the same for COPD patients. And for me, this is a really useful technique that I think is underutilized. When we talk about flow acceleration techniques, there are also devices, and one of those is the expiratory flow acceleration device, or EFA. The technology is based on the Venturi principle, which aims to increase the expiratory airflow during tidal volumes, tidal breathing even. The peak expiratory flow rate to the inspiratory flow rate is therefore greater than 1.1, and it doesn't provide negative pressure to the airways. The patient needs to be breathing, but it can be attached to a mask, catheter mount, or a mouthpiece. Here is the patient's breathing, and there is the additional airflow from a device that enhances the expiratory airflow. And the weaker the patient, the greater or the more pronounced this expiratory airflow bias will be. So the patient breathes at normal tidal volumes. You tend to find that they have a slightly increased inspiratory time. And the typical treatment is around, again, 15 to 30 minutes, like most secretion mobilizing techniques or peripheral airway clearance techniques. It has a flow setting from 1 to 5, but typically most individuals use 4 or 5. And actual compliance or participation with the technique is not needed. So the patient just needs to be able to hold a mouthpiece or tolerate a mask or the device being attached to their tracheostomy. So I've given you a whistle stop and an overview of the peripheral airway clearance techniques, some of them old, some of them new. But the bottom line is, what technique should I use and when should I use it? Now, Dean Hess, who has done a massive amount to promote respiratory physiotherapy or physical therapy, in 2017 highlighted in the proceedings of a conference summary that there is a relative lack of evidence describing the effect of the increased respiratory tract secretions on the progression of the disease. And there's even less evidence that secretion clearance techniques improve the course of the disease. Despite this lack of evidence, clinicians and patients are troubled by respiratory secretions, and standard practice calls for efforts to clear these secretions from the lungs. Indeed, a proportion of respiratory therapists' time, or physiotherapists, is spent in efforts to evacuate secretions from the lower respiratory tract. And I think that that is still pertinent for today. Now, 2013 has been quite a big year when it comes down to Cochrane publications, but also systematic reviews from other areas. So a systematic review takes on board all the randomized controlled trials, which are the gold standard for evidence. And it may be that a benefit wasn't seen with that trial due to smaller numbers. So it clumps everything together to look for whether there is a change, noting whether there is any bias within the study. So 4 have been published in 2013 with regards to individuals with cystic fibrosis. The first looked at airway clearance techniques. And the conclusion was that there is little evidence to support one technique over another technique in people with cystic fibrosis, and that they should choose the technique that best meets their need, considering comfort, convenience, flexibility, practicality, and cost. I think that's really important. When it looks specifically at the active cycle of breathing techniques, as one technique, there's little evidence to support or reject that this technique is superior compared to other techniques. And individuals basically should choose what technique they prefer. When we look at conventional chest physiotherapy, again, they're uncertain as whether there's a positive impact on respiratory function, exacerbations, individual preference, quality of life over alternative therapies, and that the evidence base is low, that it is an option. And when we look at airway clearance compared to no airway clearance techniques, I think that this is really important. The evidence from the review shows that airway clearance techniques have short-term effects on increasing mucus transport in people with cystic fibrosis. All included studies were short-term follow-up, and consequently they can't draw conclusions over the long-term effects. But it did show that airway clearance techniques are beneficial when compared to no treatment. And that's really important, because I think that that's the basis of our bread and butter. If we move on to bronchiectasis, again, 2 recent reviews. The first one concluded that stated that airway clearance techniques can be used in combination or conjunction with bronchodilators and expectorants. But again, known specific airway clearance techniques have been shown to be beneficial than the other ones in head-to-head studies. The Thoracic Society of Australia and New Zealand in Statement 20 recommend airway clearance techniques. And again, this theme that they should be individualised, that the methods and frequency need to be reviewed by the physiotherapist for efficacy. In the European Respiratory Society statement on airway clearance, you can nicely see in the blue techniques that were routinely used, and I've described some of them compared, and that some were not. But there is no evidence about the optimal frequency or number of sessions needed for airway clearance techniques. But there have been, when you look at the studies, minimal adverse events with airway clearance techniques. And that randomised control trials have assessed a variety of airway clearance techniques with oscillatory PEP, mainly flutter and a cappella, gravity-assisted drainage and active cycle of breathing techniques are the most common used. But again, there's no demonstration of superiority of one technique over the other. In a meta-analysis of randomised control trials looking at high-frequency chest wall oscillation in acute exacerbations of chronic obstructive pulmonary disease, we have here the chart for hospital stay, and it favours high-frequency chest wall oscillation. When we look at sputum expectoration, again, in acute COPD, it favours it, and that there seems to be an improvement in FEV1. However, the conclusion of this meta-analysis is that acute exacerbations of COPD may benefit from this therapy. It does produce more sputum, shorten hospital stay, but due to the heterogeneity of the research that was included, the results should be interpreted with caution. So, what do we do clinically? We've got all these techniques. We haven't got any clear factors that say we should definitely use this technique in this condition. And I think that is, although I've only highlighted certain conditions, that is a take-home message. But what I would do is I look at the problem. I look at the limitations of the patient, and I look at my possible treatment choices. And we produced this for a British thoracic statement for individuals with learning disability who have community-acquired pneumonia. And we looked at those that had an inability to cooperate or severe bulbar problems, retained proximal secretions due to a weak cough, retained peripheral secretions and fatigue, retained peripheral secretions, and those that were unable to participate in treatment. And we highlighted proximal and peripheral airway clearance techniques. And for me, this is how I would categorise the airway clearance techniques to mobilise secretion. So first of all, does my patient have fatigue or not? If they are fatigued, are they able to cooperate with treatment? And then if they are, I have choices depending on the severity of the fatigue. Could I use expiratory flow acceleration? Do I use IPV with or without chest wall strapping? Do I use IPPB with chest wall strapping and with high frequency chest wall oscillation? So it's about combining techniques, and techniques are never used in isolation for the majority. Are they unable to cooperate with treatment but fatigued? Well, I need to provide some ventilatory support. Do I add in IPV or do I use IPV alone? Do I use ventilatory support with high frequency chest wall oscillation, strapping, EFA, etc.? For those that have no fatigue, then I'm looking more at breathing exercises, PEP devices, oscillatory PEP. I've not talked about exercise as a peripheral airway clearance technique. It is really important, and I could probably talk about it for a whole 45 minutes on its own as its importance, but we should bear that in mind, Semiox. And then for those that are unable to cooperate, high frequency chest wall oscillation, EFA, IPV, or conventional treatment. So just to bring this together, and I am sure that you're all almost finished your lunch break, but here is our first patient, Jane. She's 62 years old. She's got bronchiectasis. She's on long-term oxygen therapy. Her saturations are 88%. She's on IV antibiotics, sticky secretions that can't be cleared with optimal mucolytics and hydration. She's short of breath on minimal exertion, and she's too tired to use her oscillatory PEP, but found it beneficial in the past. So she fits into the fatigued arm, and she's able to cooperate. So I have these treatment options for me. And what we used with her was IPV, and it worked really, really well. If I look at another example of someone that I remember seeing, I've got Jensen. He's an 18-year-old who has a learning disability and he's unable to cooperate. He's a wheelchair user and he's got an aspiration pneumonia. He's been requiring nasopharyngeal suction, but unfortunately that's caused a track and he's developed a pneuma mediastinum. So he's unable to cooperate with treatment, and my options are high frequency chest wall oscillation, EFA, IPV, or conventional treatment. However, he's developed a pneuma mediastinum and positive pressure is not a treatment of choice. So in this situation, we used EFA with him, and we also tried some conventional treatment. I've got Jeff. He's 56 years old with COPD. He was referred from pulmonary rehab because his secretions are limiting his exercise capacity. He was taught breathing exercises as part of the programme, but this hasn't been effective. So he can cooperate. He falls down this line. We've taught breathing exercises, but that doesn't work. He's already exercising. For me, providing a device that costs lots of money is a bit overkill at this stage. And he responded well to an aerobica device, an oscillatory PEP device, because that's what's available where we are. And finally, Jenna. She's 14, she's got SMA type 2, she's on NIV at night and for periods in the day. She has cough augmentation techniques in the form of mechanical insufflation exhalation. She's in with chronic aspiration, and typically her airway clearance sessions take an hour with MIE and conventional treatment. So she's able to cooperate with treatment. And so we have these options. So in conjunction with ventilatory support, we tried high frequency chest wall oscillation, and that decreased her treatment times and meant that she had less time where she was doing physiotherapy and was clearing quicker and more effectively. So hopefully from today's presentation, the take-home messages that I've explained are that normal secretion movement occurs via the mucociliary escalator and breathing. Secretion movement can be enhanced by oscillations or creating an expiratory airflow bias. Excuse me. Peripheral airway clearance techniques mobilize secretions into the central airways. If the cough is impaired, you're going to have to use something else for that. No one peripheral airway clearance technique is superior. Therefore, the choice of the technique should be tailored to the individual. And you may find that you need to use combination techniques, or try one technique, it doesn't work, move on. You've got lots in your toolkit. Factors that influence my choice and that you may find that they influence your choice in the future is, can the patient cooperate, and are they in ventilatory failure, or do they fatigue quickly? So I'd like to thank you for your attention, and I will stop sharing my presentation now.
Thank you very much, Michelle, for this amazing presentation. I think you did a great job covering all these techniques and materials and tools within 50 minutes of time. Not to my surprise, because I know the number of registrations as well, the number of attendees on this webinar. There are quite some questions that came in the chat. Thank you to all of you who already posted their questions, and they're still popping up. So let's take some time. Maybe I'll want to start with kind of a general question which came in, is what is the best tool to identify that there are peripheral secretions and that we need to apply techniques to remove them?
That's a really good question. You've got multiple tools within your toolkit. So you can listen, and I would always listen and auscultate to someone's chest to see if I can hear crepitus and hear secretions in the periphery. But even before that, I've got my hand on the person's chest. Can I feel where they are? Can I feel the bubbling underneath my hand? Can I move them? Obviously, other tools you may get told from the medical team that the reports of the CT scan that shows areas of collapse consolidation. If you've got an area to be targeted, you might see it on chest x-ray. The patient may self-report it to you. So you've got various tools that you can use in order to see if there are secretions present.
Great, got it. Because there, as you can imagine, there are quite some questions on the techniques themselves, but maybe let's just see if we can have the more overall questions first. In your last couple of slides, I think you mentioned fatigue a couple of times. Somebody's asking, which is your definition of fatigue, and how do you differentiate them then between the ones that get fatigued and the other ones?
So for me, and that's probably because my practice is slightly biased towards those patients that are in ventilatory failure. By fatigue, I mean those that are either on ventilatory support already, so that ticks them into that box, or those patients that you find that you're doing a short treatment time with, they can't take deep breaths. You're very limited about what you're doing with them without any ventilatory support. And so if someone said to me, I'm just really breathless on exertion, you're looking at them, they're using their accessory muscles, they're not moving around very much, then that is the type that fatigue for me, rather than someone saying, I've used my oscillatory PEP device for the last 15-20 minutes and now I'm a bit tired. So it's more going down that line of ventilatory failure. Do they need ventilatory support? Is the technique that I provide going to tip them over? And if it is, but for example, that there is an indication that they can't have ventilatory support, do I need to pick a very gentle technique that isn't going to increase their work of breathing drastically, but has the potential to clear their secretions? And that might be about positioning someone forward lean sitting, putting the device in the mouth, supporting the accessory muscles, and then trying, let's say, EFA, for example, in that situation. Or do I provide a little bit of chest wall strapping with them in a comfortable position and just see if they tolerate it, even before I move on to providing ventilatory support if they fail that?
Yeah. Okay. Interesting. Is there any guidance or research on the optimum length or the bare minimum of treatment length of time? And also, how often, as a minimum, should these techniques be applied?
Yeah, there is no guidance whatsoever. For me, it's looking about how long can you treat them for before they're completely exhausted. You might find that you end up treating little and often and frequently throughout the day, if they are particularly fatigable, or that you will get to know how long it takes in order for someone to clear their secretions. So it typically takes 5 to 10 minutes to start to get things mobilizing if the secretions are fairly thick and sticky down there. And what you're doing is you're repeating your cycles of your technique. So you do your technique, let's say the patient's not fatigued, they huff, okay. And bearing in mind, I am biased towards huffing because it tells me, and that was how I was clinically trained, where the secretions are. I go right the way down and it's bubbling and I hear it there. They're low down, they're not ready to come up. I repeat the cycle. Are they coming up? Are we moving them further up? Once I get it to the top and it clears, I start the cycle again. And are they moving? Do I hear anything there? Some people don't have an overwhelming burden of secretions, but need to clear on a daily basis. And that might be fine for those. Others you'll find need twice a day. Some, if they're fatiguing a lot and they can't, and they've got lots of secretions, may need 3 times a day. It really is titrated to the individual. But I can remember one patient who I sort of said to them, look, you do your physio when you wake up in the morning, that's great, but come on, you need to do it a bit later on. And I was very naive and very young at the time and couldn't understand that there are lots of other pressures. And I think we forget that the burden of physiotherapy compared to the burden of everyday life and everything you've got to achieve is massive. So it's what can they realistically achieve that you're getting benefit, and you're not asking them to do something that they just physically, mentally can't deal with. It is that balance. Sorry, I don't know if that's answered the question fully.
No, I think it does. I think it does. Thank you very much. During one of your examples now, you showed like, okay, what to ask for your patient. And I think on one of the slides, you also mentioned the open glottis as being crucial in many of the techniques. Yeah. It's not always easy to learn your patients how to breathe out with an open glottis. Do you have any tips and tricks to learn open glottic expiration to your patients?
Yeah, I mean, quite simply putting, the paper spirometry mouthpieces. So usually what you find is that they've got a one-way valve. You just need to pull that out. But anything that is rigid, that's a peak flow meter mouthpiece, you know, if they've got one by the bed, you pop that in the mouth, it will keep it open. Breathing in and out through that will keep the glottis open, and that does the trick. And I found that actually in vulvar patients who have normal respiratory muscle strength, so it's a slightly different group, but they are getting closure, that can work really well to do their deep breathing exercises through it. It keeps it open. They can huff, and they can almost huff and clear into their mouth even though they've got an impaired cough.
Okay, thank you. Just want to say to all the people that have had device-specific related questions here in the chat, don't worry, they will be answered later on. I hope you have a few more minutes to bear with us, but there are still questions coming in. One here now. Thank you, Michelle. The question is related to proximal airway clearance. In your paper State-of-the-Art Review in 2018, you mentioned for manual assisted cuff, ensure direction of compression in line with expiratory chest wall movement. An example, down and in with the exception of Heimlich type assist. Pressure is in and up. Can you provide further clarity why you would choose either or in practice? It's a bit of a long question, but...
So I would always go in line with how you're breathing out, because otherwise what you're doing is you're pushing the wrong way and you're not going to increase your expiratory flow, if that's the question. If the question is, would I use a Heimlich type or a thoracic compression to assist cough? Again, it depends on the patient, how comfortable they are, but combining a thoracal abdominal one, so a compression of the chest and an inward and upward thrust of the abdomen, produces research-wise and clinically the greatest change. But it will be very patient dependent. But the hand position for all of these techniques is in line with the ribs, because the movement of breathing out, because you want to increase that expiratory airflow.
Great. Yeah, now the time is there. We're moving towards the techniques and devices. A short one here. What is your opinion about mechanical insufflation and oscillation? The add of oscillations may be beneficial or not. Well, the or not is my statement. There's just a question
I was
mark.
going to say I'd like to know who put that, but it's one of my bugbears in the 98% of patients using mechanical insufflation exsufflation. For me, I don't feel that there is any benefit of adding oscillations. The oscillations are pretty rubbish on the devices, sorry. You don't feel it going down into the periphery to mobilize secretions. You're only doing it for a short period of time. And so if you're looking at MIE with oscillations to mobilize secretions up from the periphery, that's not going to happen. And that's why Jesus Sancho's studies have all been negative, in my opinion. If you are using oscillations to keep the upper airway open during a cough, or to have sort of like mini coughs or a little suck out with ALS patients with bulbar insufficiency, then I know that Tina finds that this is quite beneficial in her patient group, and she also finds it beneficial from the point of view of if they're unwell. So they have an unwell program that has the addition of vibrations, but she hasn't published anything on it, but she does advocate for that in previous workshops that I've done with her. So maybe we can have Tina talk about oscillations on another date.
Okay, we already have a topic for 2024. That's great. On the EFA device, the question is if the EFA device, if it is available to purchase on the NHS supplies, or if you have a company or a rep name.
So I don't know whether it is sort of pre-prescribable on the supply chain. Previously, when I've needed to get one, I've had to fill out an individual patient assessment form for long-term use, which I know for everyone is a real pain in the backside. Dolby Vivasol were previously distributing the device. Whether they still are or not, I'm not sure. I believe that they are. So I would contact Joe Hobbs in the UK. If you're in Italy, go to MPR.
Thank you. A question around the IPV. Thank you very much for your presentation. Is there any impact of modifying the IE ratio on the frequency during IPV therapy?
So if you are wanting to provide ventilatory support, which is the purpose of modifying the IE ratio, then you will need to have slower vibrations. So you will be using it at a slower frequency. You will also need a higher pressure. So from that perspective, it's not changing. It is not modifying what you've set. What you're doing is you need to modify the settings for what you want to achieve. So if you're going to have a greater I to E ratio, it is always to provide ventilatory support, but for them to have the added benefit of the vibrations to mobilize the secretions. Okay,
thank you. We're going to the non-oscillatory PEP devices. The question here is there a requirement for a oxygen therapy port for the handheld non-oscillatory PEP devices to connect a manometer and so that the target pressure can be read out and is about 10 centimeters of water, an ideal pressure to open the airway?
Yeah, so you are targeting that. If you don't have a port like the oxygen port in it to attach the manometer, you can always, depending on the device, not all of them you'll be able to, but you can add in sort of a T-piece, like a connector with the arm off, in order for you to look at what pressure you're achieving. But really it's about what does the patient feel comfortable with, and then what you're aiming to achieve.
Okay, a question on PEP and high frequency chest wall compressions or oscillation devices. The evidence for this type of assistive devices is largely non-existent and presupposes that the patient can follow and understand instructions. How do you approach this?
Sorry, I'm having a moment and I'm not interpreting the question. You're right that there is no evidence, but the second part that you said, Carl, sorry?
It presupposes that the patient can follow and understand instructions. How do you approach this? I suppose if the patient is not able to understand and follow your instructions.
So it depends. There are so I might not go for an oscillatory PEP device in an individual that can't understand what I'm trying to ask them to achieve. But there is good evidence for the use of PEP devices in young children who don't actually understand the concept, but breathing via the device with a mask keeps the airways open and can help facilitate airway clearance. So it's about, is the patient going to sort of understand that or not, but do they tolerate the mask on their face in that situation, and can they then have a certain amount of breaths that you're trying to get benefit from it? If you do go for an oscillatory PEP device, you do have the vibratory feedback. So what you're looking at is, are there other ways that you can describe it to the patient? So for example, we want to make that stupid noise. So are you getting, take a deep breath in, now come on, blow hard. Can we make that noise and laugh and sort of make it at a level that they can understand? If there is no way that they are able to understand that, or whoever is supervising the treatment, then I'm not going to use that with them. So it's about, if they physically don't have the mental capacity to understand the instructions on the sheet, put your head in the right position or whatever, it's about, can I find an alternative way? Can I tell them a story? Can I make something appropriate to them where I can try and get the device to work?
Okay, a question which is probably very much in line, and maybe the answer is already covered at least partly by your previous answer, but it's a shame that PEP masks are not included for non-collaborative patients, as we are seeing more and more benefit with patients with neurodisabilities and applying PEP passively. The latest Cochrane review on pediatric population suggested as emerging evidence for it. Not sure about the difference with PEP versus EFA in this cohort.
So yes, I agree with you that I've just said in pediatrics, there are quite a lot of patients that will be using PEP devices, and you can use it that way. My practice is always that my patients are more slightly severe than the ones that you're seeing in the community. And so I apologise if my presentation has been slightly biased towards that. I do think you're right that if a patient is non-fatiguing, then potentially they could benefit from that. With regards to PEP versus EFA, I think the verdict is still out, and that further studies are warranted to see if one is more superior than the other, but both have a role and definitely help in order to clear secretions, decrease hospitalizations in the small work that has been done, and hospital length of stay.
Great, thank you. We have two comments left, and then there is two questions left, and then there is one comment which we will take internally, where there is a question about you coming back on a recently published article. But the two remaining questions we have for today is if you have any recommendations if patients develop bloody secretions with or during chest therapy.
Yeah, I mean, it depends on how bloody they are. Some people, just by clearing some secretions, will have an area that has been affected by inflammation, and you're just sort of clearing it. So if it's just like a little bit of old brown stuff or tinily streaked, then I would continue with caution. Anything more than that, I would want my medical team to review in order just to see what's going on. So it's that balance over what are they normally like? Is this abnormal for them? And therefore, where do I go with that?
Okay. Last question so far. Well, I think it's the last question overall. First of all, thank you for a fantastic talk. Please, could I ask about timing of DNA SNPs in neuromuscular disease? Would you reduce the time versus using CF? And could you point towards any guidance for this? Thank you. And I see you smiling, so maybe you know who.
I'm wondering, maybe, but it's one of those. There's no evidence. There's no guidance. Actually, does hypertonic saline benefit more than DNAs? Not entirely sure. There is the paper from the Brompton that showed that neuromuscular neurodisability patients with hypertonic saline reported ease of clearance. There was less antibiotics, less hospital stay. So I would potentially try that over DNAs, but we did have a group of patients that seemed to acutely unwell benefit from it. Usually it was given an hour or so before physiotherapy, and if things hadn't sort of loosened up, then it would be given a little bit earlier. But it's a little bit like trial and error, and what works in CF doesn't necessarily work in neuromuscular disease and neurodisability, so you can't necessarily extrapolate it over. So clinically it works in some people, it doesn't work in others. It's very difficult to get long term, and so I would just be mindful of prescribing it or getting it prescribed if you want it long term. But if that's the only option, then by all means go ahead.
Okay, that was it. Thank you very much, Michelle, both for your presentation as well as for all your interesting answers to the questions that came in.